I'm an academic F1 doctor currently working in Birmingham, and today we'll be doing acute kidney injury. So acute kidney injury, before we begin, I just wanted to kind of briefly just explain to those who are new to BiteMedicine what we are and what we offer. So essentially at the moment our website offers three major products. The first being a question bank that offers a fantastic opportunity to kind of go through a single case-based discussion on one patient. So you kind of do a multi-step SBA format tackling all the major topics within medicine and surgery. There's then an online textbook to supplement this learning. And finally, we do these regular live webinars. So today will be an example of what our live webinars are. The online textbook is something that I'm particularly proud of that we do. And then finally, here is our question bank that takes you through the main steps and really helps consolidate that learning. If you haven't yet made yourself a premium account and you wanted to, you can get 20% off today with the discount code Richard2021. So that's the plug. Now let's do the webinar. So renal was one of those topics that I absolutely adored at medical school, but was one that took me a long time to fully access. And I think the way you need to approach it is to realize that there are lots of weird and wonderful kidney conditions and diseases, but actually taking the time to learn those is not as beneficial as learning these three major topics here on the left of your screen. So AKI, CKD, and nephrotic versus nephritic syndrome. If you can get this down, you will be well on the way to having conquered renal as a topic. Obviously, within these areas, you need to know your causes, how to investigate and manage, and any potential complications. Once you've got this general sort of baseline down, the specifics will fall into place. Okay, now all of these weird and wonderful conditions on the right of your screen actually feed in to these general ones on the left. So I would very much advocate learning renal from an AKI, CKD, and nephritic point of view. So today's session, we're going to be covering three patients, so three cases. And if I just go to the chat, does anybody know why I've chosen to do three patients for this session? You're all shy. So, three types of AKI. Yep. Three different causes of AKI. There we go. I'm seeing it now. Brilliant. Yeah. So pre-renal, renal, and post-renal AKI. So when we think about AKI, we think what is causing it, and we kind of sort of roughly divide it into things that are occurring before we get to the kidney. So the blood supply that supplies the kidney. The intrinsic sort of tissue within the kidney, and then post-renal issues, so things that involve the lower urinary tracts themselves, so ureter, bladder, urethra even. And then we'll quickly touch upon complications of all AKIs, because I think it's a really good thing that you as future clinicians should know about when you're faced with it in reality. So without further ado, let's kick off with our first case, Mrs. Lowe. So she's an 86-year-old female who lives in a nursing home. And unfortunately, about half the residents of the nursing home have been suffering with a norovirus outbreak at the moment. So this is the winter vomiting bug. And Mrs. Lowe is one of them. You can see her here on the right. She's been vomiting multiple times a day, and the staff have noticed she seems more confused than usual. Past medical history includes type 2 diabetes, hypertension, and atrial fibrillation. And if we look at her observations here, again using the chat, does anybody have any major concerns about these observations? We've got a heart rate of 110, BP, yeah, you're spotting it. So BP is low, definitely. And she's also tachycardic. And I'm seeing a couple of you there saying shocked. So yeah, potentially she has got some features here of shock. So low BP, raised heart rate, otherwise the obs are okay. And so that leads us nicely onto our first question of the day. So for those who haven't done a BiteMedicine webinar already, if you've got a tablet or a phone or another browser open, if you go to menti.com, and when you get there, you type in the code 8784520. That will allow you access to our first question of the day. So I'm just going to quickly head over to menti.com. So, question is, what is the correct resuscitative management for this patient? So we'll start with a question that pretty much came up every single clinical exam I ever sat at university. So definitely one that you all need to be guessing correct every time, okay? It's almost a guarantee. So the options are: encourage increased oral intake, 500 ml of 4% gelafuscin intravenous over 15 minutes, 500 ml of 0.9% saline intravenous over 15 minutes, a liter of saline over 4 hours, or COVID-19 swab test. So I'll just wait for 10 more of you to answer, and then let's see what you guys are going for. So, bang, okay, so the majority clearly here getting it right. Well done, 81% of you. So yeah, 500 ml of saline over 15 minutes is the ideal resuscitative management for this patient. So just having a look at these, if you had a patient whose blood pressure is below 90, I think you've gone past the point where you would rely on oral intake alone. You need to supplement this really. Gelafuscin is an example of a colloid fluid, okay? So it helps with increasing oncotic pressure, but is not, based on current guidelines, the correct resuscitative fluid. Instead, we would opt for a crystalloid fluid, in this case being saline, and we usually say a stacked bolus of saline, so give it as quickly as you can, which is roughly about 15 minutes to a normal size cannula, and that would be a good starting point. Something you can do when you're the F1 or the physician's associate on the ward, if you want to see is your bag of saline going to do anything, before you give it, just try lifting the patient's legs up, okay, and then redoing their blood pressure, because essentially you're going to just bring that blood back up to their body, increase venous return, and you should see a response. And if they have a sort of transient response, you think, right, I should give them some fluid. A liter over 4 hours is a bit too slow, and of course, COVID-19 swab test is just a bit silly. So if we go back to the PowerPoint. So just a couple of things to note here. We've got the norovirus outbreak, which is something that has kind of been overshadowed by COVID this year, but it's something that used to, or probably will again, plague the NHS and particularly plague care homes. But I think with the kind of current emphasis on good hand hygiene, this is kind of gone down a little bit, which is fantastic. She's also a little bit confused. So you would be thinking here, maybe this patient has an element of delirium, so acute confusion. So her obs stabilized thanks to the 81% of you that gave the correct fluid resuscitation, and the patient undergoes the following basic investigations over the next 6 hours. So firstly, her bloods, some notable parts of her bloods. So her urea is 20. We've given all the reference ranges here. Her creatinine is 200. Her urea creatinine ratio, now this is something that you won't see on blood tests in the hospital, but I would really, really advocate for you guys to kind of have this in the back of your head when looking at blood results. It's a really useful measure, and we'll talk about it a little bit later on. She's catheterized, and she's had her urine output measured hourly, And in the first hour, it's 20 mil, second hour, 20 mil, and it continues at 20 mil until by hour 6, it's just 15 mil of output. And we've given her weight there. So a question for the chat, nice and simple. Is this AKI? Does this patient have an AKI? That is the question. And would anyone like to suggest exactly why? I'm getting a few yeses. Anyone want to? Someone said due to the vomiting and dehydration. Yeah. Brilliant. Yes. So, Ryan, thank you very much. You've written it there. So, less than 0.5 mils per kg per hour. So, in a second, we're going to look at some of the definitions of AKI so you can all be confident in saying yes or no to an AKI. But the key one here is that this patient has low urine output. So, an average person should be passing about 1 mil per kilogram per hour of urine. And so what you need to do with this patient is just look and say, well, look, if they're passing 20 mil roughly an hour, that's 20 mil per hour. Then you divide it by their weight. So 20 divided by 50 is 0.4 mils per kg per hour, which is less than 0.5, which therefore meets our definition of AKI. So let's have a look, because there's a number of different ways that you can confidently diagnose AKI. So they're all based on the KDIGO guidelines. So KDIGO is like the NICE of the kidney, and they have these fantastic PDFs that are very detailed, but actually very helpful for kind of pulling out the salient points about various kidney diseases. So their first sort of definition of AKI is they simply say it's an abrupt and sustained decrease in kidney function. But that's kind of waffly. What does it actually mean? Well, they can define it as a rise in the serum creatinine of more than 26 micromoles per liter within 48 hours. Now, the issue with our patient is we've never met her before. She's just come to hospital. We don't have that baseline of what she was 48 hours ago. So we can't diagnose AKI or fat. The next one is, have they had a serum creatinine rise of 1.5 times the baseline? Again, the issue here, and this is an issue that we see all the time in A&E, is that we don't know the patient's baseline. But the final one, and the best one for new patients, is a urine output of less than 0.5 mil per kg per hour. And the key here is for 6 consecutive hours, okay? So, just seen a couple of things in the chat. Let's just have a look what you guys are saying. So, I can repeat the code. Yeah, absolutely. So let's just, if those who wanted to play along with the, so the code, if you guys want to just note it down for the rest of the session, is going to be 87 84 52 0. And yeah, we'll get some slides out after this, guys. So this patient does have an AKI. And if we look at, you know, some facts about it, up to 20% of people who come into hospital have an AKI. Okay, it's super rampant. You need to be on the ball for it, and it can present in a whole number of different ways. And actually, in our elderly population, it's really, really common and can sometimes be the only explanation for, say, you know, reduced mobility, off legs, even just acute confusion. So be looking out for it. The risk factors: advancing age, hypertension, diabetes, which our lovely Mrs. Lowe had. Also, CKD predisposes to any acute injury. Medications is a massive one, and we're going to cover the key ones in this session so that you guys are all prepared when it comes to being out on the wards. And hypovolemia is another massive one. So if anyone has, you know, not been eating and drinking like they should have been, as is the case of Mrs. Lowe, who'd been off her food and vomiting, they're at massive predisposition. And the reason we worry about it so much is it's really common and it's really, really fatal. You know, if I think it's something like if a patient is in stage 3 AKI, their mortality rate can be as high as, you know, half, which is terrifying. So you need to be able to spot it early on. So staging, I don't want to labor the point too much because it goes beyond the sort of scope of what you're expected to know at medical school. But there are kind of two broad staging tools that are used. Is the rifle tool and there's the akin tool, so AKI network, that stands for. And broadly speaking, the reasons that I've mentioned it in this is because the higher the stage of AKI, so the more severe your AKI is a good predictor of how long you're going to be in hospital. If you're moved to ITU, how long you'll be on ITU. It predicts your mortality outcome, and it also suggests whether or not your kidneys are ever going to recover. So in terms of the stages, we use 0.5 mil per kg per hour over 6 hours as stage 1, over 12 hours for stage 2, and over 24 hours for stage 3. But again, this is way beyond the scope of medical school. It's just something to have in the back of your mind. So, etiology or causes of a pre-renal AKI. I think the thing I want to say here, or to stress, is that everything converges on a reduced blood flow to the glomerulus. That is the key point. And so an example of this would be volume loss. So if you are vomiting or have diarrhea, or you're feverish and you're losing fluid through sweat, anything that leads to a reduced blood volume will lead to reduced blood flow to the glomerulus. So that's one. If your heart is not pumping properly, either due to heart failure or some sort of cardiogenic shock, again, you're not going to be perfusing your kidneys properly and getting that blood to the glomerulus. Another really important one is systemic vasodilatation. So if you imagine your renal arteries that come off the aorta, if, for example, you're in anaphylactic shock or septic shock, you get this systemic vasodilatation that drops the pressure in those renal arteries and thus drops the blood flow to the glomerulus. And finally, the renal vasculature itself. So in those arteries, sometimes they can become stenosed due to either atherosclerotic changes or some sort of funky condition like fibromuscular dysplasia. And if that occurs, again, you're going to get reduced blood volume to the glomerulus. So there's a whole host of different causes, but ultimately you need to be thinking anything that's stopping blood getting to the glomerulus is going to cause a pre-renal AKI. And if we go a little bit further down, if you've got decreased blood flow to the glomerulus, then you're going to have decreased blood filtration, which is going to lead to reduced urine output, raised urea, and raised creatinine. So if you're not filtering out your urea and your creatinine, they're going to rise in the blood. And the reason that your urea has 3 arrows there is because your urea actually goes up proportionally more than your creatinine. And the reason being is because the kidney itself, or sort of our nephron, our tubular structure, still has the reabsorption mechanisms that allow it to pull urea back into the blood. So not only are you not filtering urea out, any of the urea that does manage to get into the tubules, that also gets reabsorbed. So your urea is going to go up exponentially. And that's really important because when we look at a set of U's and E's, and we're trying to work out if a patient's got a pre-renal AKI or a renal AKI, looking at that ratio between urea and creatinine is really, really useful. So if their urea is exponentially higher than the creatinine, and that urea-creatinine ratio is high, then you can think maybe this is a pre-renal AKI. Someone's asked why urea gets absorbed. So it's just part of the kind of urea cycle. There is a reabsorption mechanism, whereas creatinine doesn't get reabsorbed. If you remember from your kind of homeostasis lectures, creatinine is something that is freely filtered and freely secreted, but not reabsorbed. So, clinical features. Now, this pretty much goes for all the AKI, so we'll just cover it here, but we're still kind of focusing on this pre-renal case. But the things to watch out for. So, in an ideal world, everyone would have, this low urine output or oliguria, and it would be really easy to spot an AKI. But sometimes they can have really nebulous features like confusion, nausea, or even shortness of breath, and they can mask the AKI. So you need to make sure that when they come through ED, they do get that euthanasia done pretty quickly if in anyone that you have the slightest suspicion of an AKI for. And then some signs to look out for. Well, if they're not getting rid of that, if they're not passing urine, they're not filtering their blood properly, they can get an increased blood volume, get sort of extravasation into the tissues, leading to peripheral edema or even pulmonary edema. So you might hear crackles on the lungs. They might have a raised JVP. So these are all sort of quite classic sort of heart failure-like signs, but just essentially represent sort of fluid overload. And then you might get some features that reflect a sort of an actual kidney disease itself. So they might have blood in the urine, which is a really good sort of sign of a kidney disease, or even proteinuria. And does anybody know how proteinuria can present as a physical symptom? Just looking at the chat to see if anyone has any ideas. Frothy urine, yeah, exactly. Yeah, I can't exactly vouch for what that would look like, to be honest, or if anyone would ever really notice it. But supposedly the textbooks all say frothy urine. Fab. So question 2. So we'll head over to menti.com, and for those who haven't seen it yet, the code is in the chat again, so 87845220. So question 2. Which of the following oral medications should be suspended for Mrs. Lowe in view of her pre-renal AKI? So we've got her drug chart here, and she has got on her drug chart amlodipine 5 milligrams daily, bisoprolol 2.5 milligrams daily, paracetamol 500 milligrams 4 times a day, ramipril 5 milligrams daily, and lansoprazole 30 milligrams daily. So this is a pretty standard set of drugs that a person over the age of 80 might be on. And for those who haven't seen these kind of notations before, like OD and QDS, this is just sort of old money Latin that somehow has persisted in medicine, like a lot of traditions. But essentially just means OD is daily, BD twice daily, TDS is 3 times daily, QDS 4 times daily. So which of those drugs do you guys think you should stop in view of the pre-renal AKI? I'll just give 10 more people a chance to answer. Okay. So, right. So 81% have gone for ramipril, same 81%, man, and 15% for amlodipine. So well done to the majority. Yeah, absolutely. So ramipril is an example of an ACE inhibitor, and you definitely need to stop that in pre-renal AKI. Just looking at the chat, does anyone know the specific reason why we stop an ACE inhibitor? Yeah, fantastic. Yeah, so the main reason is this narrowing of the afferent arteriole. So it causes constriction of the afferent arteriole. So that's the vessel going into the glomerulus. And if you constrict that, then you're going to decrease blood flow to the glomerulus, which of course is that kind of converging point in that diagram I showed you. And some other drugs that can do that. So contrast that we give for all sorts of imaging is another one that can cause that constriction of the afferent arteriole, and hence a pre-renal AKI. So you need to be really careful when giving contrast. Someone's asked about, do we stop angiotensin receptor blockers too? Absolutely, yes. So all the extents and purposes sort of treat them as the same thing in terms of kidneys. So management. So we've covered the fact that we need to resuscitate our patients with a crystalloid. I think it's good practice to do serial VBGs, so VBGs at different time points to monitor whether someone's lactate is going up or down. So lactate is a rough measure of tissue hypoperfusion, the buildup of anaerobic respiration. And then it's important to establish some sort of maintenance fluids. It used to be the case that you do 1 salty, 2 sweet over 24 hours. So that meant 1 bag of saline, 2 bags of dextrose. But NICE guidelines have updated since, and it's a little bit more complex than that now. There's some sort of suggestion that you need to be working out exactly how much sort of electrolytes this individual patient, based on their weight, requires. We did a recent IV fluids webinar that you guys can check out on YouTube if you're interested, but it goes into quite a lot of detail. So kind of beyond the scope of this lecture today. Really important to know the key offending medications that you need to stop. Beg your pardon, we talked about ACE inhibitors constricting. They also dilate. Beg your pardon, I got that the wrong way around. So they dilate your efferent arteriole. It's ibuprofen and naproxen that constrict, but it's the same outcome. So if you have your efferent arteriole, which is the arteriole leaving the glomerulus, if that dilates, that will drop the pressure in your glomerulus, which ultimately leads to reduced filtration. Beg your pardon there. So ACE inhibitors dilate your efferent arteriole. NSAIDs and also contrast constrict the afferent arteriole. And diuretics reduce flow through the tubular capillaries. So these are all the little capillaries that line our loops of Henle. And if we have less flow going through there, then we're going to have less reabsorption of our essential electrolytes. So all of these are bad news when it comes to AKIs. And I can't tell you how many times I've been to see a patient in ED in the last 4 months. I've been sensible enough to recognize that they have an AKI on their bloods or on their urine output. And then when I've gone to kind of discuss the patient with the consultant, they've said, well, you know, did you stop their various drugs? And there's always one that I miss. There's a whole list of different drugs. These are the main offenders that you need to be aware of, okay? And these are the ones that will be tested repeatedly on your med school exams. So, some things to mention that you might see. I think the reason I put these on is because sometimes textbooks don't get updated, question banks don't get updated. So KDIGO no longer recommends the use of low-dose dopamine. This used to be something that was recommended in patients with an AKI. It is, however, recommended that you can use vasopressors, so things that cause constriction of your arteries, if a patient has vasomotor shock. So if they've got massive vasodilatation, that would help with an AKI if it was pre-renal. But the important thing to say about vasopressors is that is way beyond the scope of an F1 doctor, and definitely beyond the scope of most ward doctors. So usually when you get to the point where you need vasopressors, you're entering the territory of ITU. So as a brief recap of pre-renal, before we go on to the slightly more exciting renal stuff, our main causes: volume loss, reduced cardiac output, systemic vasodilatation, and excessive constriction of the afferent arteriole. They can all lead to reduced blood volumes to the glomerulus and reduced filtration. Distinguishing features. So if you're ever asked by a consultant to explain or justify why something is pre-renal, the history should be in keeping with these above causes. They should have a high urea to creatinine ratio, and that's the reason being is because your urea is not properly filtered, as is your creatinine, but the kidneys are still working themselves, so you're still reabsorbing that urea. And something that's a bit more fine print, you should have a low urine sodium. So your kidney is still able to reabsorb sodium through the tubules, and therefore you will not be urinating a lot of it out. So your urine sodium will be low. And that's something important to remember later on when we cover renal AKIs. And management, essentially, fluids, and get them to ICU if they are in vasomotor shock. Fab. So, quick 10-second breather, and we will move on to our next case, which is Mrs. Bridney. You can see where I got the imagination for these names. So, case 2, Mrs. Bridney. She is a 57-year-old female who is being treated in hospital for sepsis of unknown origin. So this is a term that gets bandied around a lot. Sometimes you'll just see it in the notes as SUO, or sometimes PUO, so pyrexia of unknown origin. This is essentially where someone's got an infection and we've got no idea where it's coming from, or we have multiple ideas of it. It could be there, it could be there. They've got past medical history of type 2 diabetes. And in the last 12 hours, she's been noted to have a urinary output of 0.4 mil per kg per hour. So for those who are really paying attention earlier, anyone remember what stage AKI this patient has? Stage 2, fantastic. Yeah, that's great. So definitely need to be worried about this patient, and particularly because despite regular IV fluids and catheterization, her urine output has not improved. So she's a little bit tachycardic. Her blood pressure it's okay, and she's sort of got a low-grade fever here. And here are her medications. So she's on metformin, which is a first-line diabetes drug, biguanide, that increases or reduces gluconeogenesis and increases insulin sensitivity. Enoxaparin, so that's a drug that you would get a lot of your patients on in hospital. So a prophylactic dose to kind of protect against venous thromboembolisms. And then these 3 drugs here, so AMA or AMG are a classic cocktail of antibiotics that you give for sepsis of unknown origin. So AMA being amoxicillin, metronidazole, amikacin, and AMG being amoxicillin, metronidazole, and gentamicin, which is the more commonly used one. So this is what she's on. And let's go to question 3. So it's the same thing again. If you head over to menti.com, code 8784520. And just while people join, someone's asked, do you often measure urine sodium? Not very regularly. I have done it from time to time, usually on the request of the renal physician or the endocrinologists, usually looking at things like syndrome of inappropriate ADH, but not usually for AKI. So, which of the following medications is most likely to be responsible for this patient's AKI? We've got metformin, enoxaparin, amoxicillin, metronidazole, and amikacin. So, just let a couple more of you answer. Fantastic. So let's see where you've gone. Ooh, okay, interesting. A little bit more split here. So 34-34, you can't all be right. So the answer is amikacin. So someone in the chat asked, is amikacin an aminoglycoside? Yes, it is. So this is a really important one, question to know about, and I purposefully put metformin in there as a distractor. Okay, so this is key. So amikacin and gentamicin are examples of aminoglycosides. Okay, which classically you will have learned is ototoxic and nephrotoxic. So can damage hearing, can damage the kidneys. Metformin, some of you may also have in the back of your mind an association between metformin and AKI. So metformin itself does not cause AKIs. However, in someone with poor renal function, if they are on metformin, they are at an increased risk of developing lactic acidosis. Okay, so that's the key fact you need to remember there. So if this question had said, which is the most important medication to stop, both metformin and amikacin would have been correct. Amikacin because it could be causing the AKI, and metformin because they're at risk of lactic acidosis. But here it was just asking which is the medication responsible, therefore the answer is amikacin. So I hope that makes sense, and you guys have, committed that to memory. So it's a good one to watch out for in your exams. So we've covered sepsis of unknown origin. We said that they are in sort of stage 2 AKI, which is very worrying, and we've acknowledged now that amikacin is the likely drug. So if we look at what is actually going on in a renal AKI, you can break it down really nicely based on the structure of the kidney. So this is a nephron. Most of us will have about 2 million of these, 1 million per kidney. And the rough sort of anatomy of the nephron is you've got the glomerular structure here, sort of Bowman's capsule. You've got your proximal convoluted tubule, your loop of Henle, distal convoluted tubule, and then collecting ducts becoming the ureter. And between this tubular system, you've got this parenchymal tissue or interstitia, and then you've got the intrinsic blood supply of the kidney. So this is not the arterioles that bring blood to the glomerulus. This is the actual blood supply that keeps the kidney alive, okay? Now, glomerulus, tubules, parenchyma, and kidney vascular supply can all have issues go wrong with them that can all lead to a renal or intrinsic AKI, okay? So something to be aware of. So, starting with glomerulus, so this is where you have all your funky glomerulonephritis conditions, okay? Now, unfortunately, I would love to talk for hours about each of these in turn, but there just simply isn't enough time, and this is meant to be more of a brief overview than an in-depth discussion on glomerulonephritis. There are some fantastic textbook entries on our website, and there's also a load of just information out there on the web on these different conditions. And I hope that this lecture, if anything, will act as a springboard for your kind of wider reading. But any condition that can damage or cause inflammation in the glomerulus can lead to an acute kidney injury, just essentially by disrupting that filtration function. However, more commonly, these glomerulonephritis cause a nephrotic or a nephritic syndrome. So nephrotic being leakiness of the glomerulus, loss of protein in the urine, leading to hypoalbuminemia, so low albumin in the blood, and subsequent edema. Nephritic being loss of blood in the urine, hypertension, and oliguria. So that's the more common presentation of someone with these glomerulonephritis conditions, but they may come into hospital with just, low urine output and some, aberrant usinase. Unfortunately, as I've said, it's beyond the scope of a single lecture, but just if you're kind of thinking of the renal subject as a whole, this is the glomerular section. You've then got the interstitium, okay, or the parenchyma. So this is all the sort of extracellular sort of substance that surrounds the tubules, as well as the kind of supporting matrix. And in here, you can get a condition called acute interstitial nephritis. Now, this is more likely to be tested at finals level. And again, there isn't much to say about it in terms of how it can cause acute kidney injury, other than in certain drugs, so things like NSAIDs, penicillins, acyclovir, you can have a sort of hypersensitivity-like reaction where you get neutrophils and eosinophils infiltrating through the parenchyma and causing an inflammatory reaction. I kind of think of it a little bit like lung fibrosis. It's you've got a pathological process going on between the alveoli in that kind of supporting structure. Same here with the acute interstitial nephritis. The key features that a patient will usually present with is not actually AKI. It tends to be a rash, joint pain, and eosinophilia, so raised eosinophils on a full blood count. But it's just important to mention that they could come in with poor urine output and have this underlying disease. That's the glomerulus and that's the interstitium. And then we've got tubular. So this is probably the most relevant one to this webinar. So in the tubules, we've got all these lovely little cells lining the tubules, and you can have something called acute tubular necrosis, which really does what it says on the tin: death of the tubule cells in the acute setting. And what happens is, if you imagine a nice pipe and your tubule cells die, they merge, they're going to migrate into the tubule, block the lumen, and of course that filtrate that should be moving its way through the loop of Henle gets blocked, and you get back pressure, and it goes all the way up, this pressure all the way back to the glomerulus, and you reduce that pressure gradient from either side of the glomerulus, leading to reduced filtration and subsequently a drop in urine output and failure to filter the blood properly. So why do these cells die? Well, you can get ischemia, so a particular region of the kidney may die due to infarct, and we'll cover that a little bit later. One classic cause is myoglobin. So I'm not sure if she's here, but there's a student from Birmingham who I was chatting to about this week, who I invited to this webinar, specifically about rhabdomyolysis. So any patient who's come in with a fall and a long lie, we worry about breakdown of skeletal muscle or rhabdomyolysis and the release of myoglobin, which is nephrotoxic. So it gets filtered by the glomerulus and then it damages these tubules. The classic offender in this case here, so our aminoglycoside antibiotics, amikacin and gentamicin. Got to be really careful with these. One of my patients, literally as I went home, I had to prescribe a stat dose of gentamicin for, and on top of that, I made sure that I gave them fluids to run overnight, just to help with their kidney recovery. Then you've got some weird and wonderful lead, ethylene glycol, or antifreeze that can all damage the kidney. So you might have a weird SBA, like a child drinks some antifreeze or something. And then acyclovir can cause acute tubular necrosis. This is something that was never really drummed into me in medical school. And in the last 4 months on my elderly care placement, I think I've cared for about 5 different patients who've all developed really quite profound acute kidney injuries secondary to acyclovir. So it's just one to be aware of. The good thing about acute tubular necrosis is that the tubular cells can regenerate quite well. And if you remove the offending agent, then your tubules can recover and you can get your glomerular filtration rate back up to baseline, which is really, really good. And then finally, we've got our renal vascular supply. So this is the intrinsic supply of the kidney. Don't confuse it with the supply that gets filtered. And this can become compromised. So you can get tiny microvascular thrombi, such as in thrombotic thrombocytopenic purpura or hemolytic uremic syndrome, that can lead to mini infarcts of the kidneys. Not that common, but just something to be aware of. If you're in an OSCE and you're asked to give a myriad of different causes of AKI, it's a good way to split this. So that's the pathophysiology. So let's head over to question 4, which is one of my favorite questions, and I think is something that could very, very easily be asked in your exams. So same again, we head over to Menti.com, 87 84 520. Just while people join, somebody's asked, for certain types of nephritic and nephrotic diseases, hypertension is treated with an ACE inhibitor. Yeah. Could this lead to an AKI? Yes. So it's a difficult one. In CKD, we treat with ACE inhibitors, but we stop them in AKI. There's a whole host of different reasons, and the literature is kind of sketchy on it. But essentially, if your ACE inhibitors are renoprotective in the long run because they kind of prevent hypertension, and that's obviously leading to, over the long run, deteriorated kidney function. But if they develop a sudden drop in kidney function, then you need to stop the ACE inhibitor. I have done a session on CKD in the past where we cover this, that we could potentially do again with GKT in the future if that was something you guys were interested in. Anyway, so I'll just let a couple of more of you file in. So the question today is, given the likely cause of this patient's AKI, which of the following is most likely to be correct? Urinary sodium will be low. The serum urea creatinine ratio will be high. Serum complement levels will be depleted. The patient will have muddy brown casts in their urine, or the patient's serum pH will be 7.55. So a little bit more of a puzzler, but something that could definitely be asked as a top decile question to work out who is on top of their game. So let's have a look what you guys have put. Okay, so 44% of you have gone for the muddy brown casts, 22% have gone for a serum urea creatinine ratio being high. So let's have a look at the answer. It is the muddy brown casts. So let's talk about this. I'll just work my way along the line explaining why each one is right or wrong. So urinary sodium will be low. So if we think this patient's got an acute tubular necrosis, so their tubules that are involved in reabsorption have died, they're no longer going to be able to reabsorb like you would want to. And so if you can't reabsorb your sodium, you are going to excrete it in your urine. So your urinary sodium is classically high in acute tubular necrosis. Same goes for the urea creatinine ratio. You can't reabsorb your urea if your tubules are damaged. So your urea creatinine ratio tends to actually be low in renal AKIs. So less than 40:1, and we'll cover that in a second. Serum complement levels will be depleted. So serum complement, this is a inflammatory marker in your blood that's involved in the acute inflammatory response. Can sometimes be depleted if you are having ongoing inflammation, but that tends to be with glomerulonephritis, not acute tubular necrosis. Skipping ahead to the other wrong answer, a serum pH of 7.55. So that's alkalotic. What we actually tend to see in AKI is patients become acidotic. So failure to, or disruption to the tubules leads to inappropriate proton balancing. So you end up essentially retaining too much acid in your blood, causing an acidosis, not an alkalosis. And another reason is because when your tubules are damaged, you fail to reabsorb potassium. And so your potassium levels go down, and then you get this proton potassium shifting, which leads to acidosis. So focusing then on the correct answer, the patient will have muddy brown casts. So this is pathognomonic for acute tubular necrosis. So pathognomonic being, if it's present, that's the diagnosis. So muddy brown cast, this is essentially what you are finding in the urine is the dead tubular cells. And under microscopy, you can see them as these little muddy brown casts. So well done to the 46%. And let's head back. So investigations, what the so-called renal workup. Whenever we have a problem with a patient on our ward and we email the renal physicians, they ask us for this renal workup. So make sure you do their U's and E's, and particularly you can measure their urea creatinine ratio. So I've done a worked example down here of what I actually mean by this. So if a patient's urea comes back as 10, that's 10 millimoles per liter, and creatinine 250, first thing you've got to do is make sure that the units are the same. So this comes out as 10,000 micromoles per liter against 250 micromoles per liter. which when you simplify it, gives you a urea to creatinine ratio of 40:1. Okay, and if we look at this helpful table here, 40:1 or less tends to point towards a renal cause of an AKI. So I use this all the time on the wards when I'm trying to work out what's going on. It's really, really helpful. If your urea is staggeringly more high than your creatinine, so your urea creatinine ratio is high, think pre-renal. It's less than 40, think renal. If it's in between, it's not actually that helpful. It might not be bang on. So some other things that are part of that renal workup. So serum free light chain. So these are immunoglobulins that might be raised as an indicator of myeloma or a B-cell malignancy. So if you're having excess immunoglobulins, they can damage the kidney. Serum complement, so it's important to measure this. It's a sign, or it's an acute inflammatory marker that might be raised or depleted in certain glomerulonephritides. You've got some weird autoimmune rheumatological tests here that oftentimes can be linked to kidney disease. And it's really important to do a blood-borne virus serology. So looking at the antibodies against common viruses like HIV and hepatitis C. And the reason being is patients with HIV and hep C are a predisposition to developing other glomerulonephritides. So things like membranoproliferative glomerulonephritis, focal segmental glomerulosclerosis. Not exactly clear why, but it's really important to rule these out. Then, in addition to the bloods, you'll be doing urine tests. So a quick dipstick on the ward never goes amiss. So it might show proteinuria or hematuria. Make sure that if you've got that sample and you've dipped it, send it off to the lab for further quantification with something like a urine albumin creatinine ratio. You can send it off to the lab for microscopy, and that might reveal these muddy brown casts that we talked about. And you can also send it off for a urine sodium, which we said the urine sodium will be high in the renal AKI because you're not reabsorbing that sodium. And then they might ask for some imaging. So sometimes it might not be a biochemical process or some microscopic disease. It might be something structural, like a cyst within the kidney itself that's damaging normal kidney function. And they might even ask for a renal biopsy if after all of these they still haven't got to the bottom of it. So that is what we call the renal workup, and it's something that you can have in the back of your head, so that when you are F1 doctors or PAs, you think, actually, before I drop the renal team an email, I could even start to send off a couple of these more basic tests like the urine dipstick, the urine microscopy, which might give us our answer. So management of renal AKI, one size does not fit all, is the take home I got from this absolutely whacking PDF on from KDIGO. Essentially, every specific glomerulonephritis condition, every specific acute interstitial nephritis, they all have a different regimen of immunosuppressive medications to dampen the immune system. So you're not expected to know them. The key thing for renal AKIs is in acute tubular necrosis, which is the main one that I would focus on as a student. Your tubules will recover, or should recover, if you suspend the offending agent. So stop the aminoglycoside or stop the acyclovir or whatever, and never be afraid to call your renal team to get some help. So quick recap before we go on to the last 10 or so minutes of the session. So renal causes, we've covered them there. Distinguishing features, so how to spot a renal AKI. It may not be responsive to fluids or catheters. They'll probably have some sort of complex medical history. We mentioned about the blood-borne viruses or the autoimmune conditions that you screen for. They may have background history of these. There might be some nephrotoxic agent like aminoglycosides or acyclovir. They should have a low urea to creatinine ratio. So this is because they are not able to reabsorb urea. So in this case, their urea creatinine ratio tends to be low, and they are not able to reabsorb sodium, so they urinate it out, so they have a high urine sodium. And we've said management is varying. So on to the last 10 or so minutes. Finally, we finish with Mrs. Post-renal. So she is a 74-year-old female who's admitted to hospital with suprapubic pain and is passing very little urine in the past 24 hours. She denies dysuria or hematuria, and past medical history includes osteoarthritis and hypertension, for which she takes amlodipine and amitriptyline. Examination, as we can see on the right here, reveals suprapubic tenderness, and when a catheter is inserted with ease, she cries with immediate relief. So, question 5, nice and simple one. Which of the following was the most likely culprit for this patient's urinary retention? And your options here are amitriptyline, so one of her drugs, urinary tract infection, kidney stone in the ureter, urethral stricture, or bladder cancer. Apologies to those in the chat whose questions I haven't been able to answer. It's a little bit like spinning plates when we do this. But I'm happy, I'll leave my email at the end for anyone who wants to ask any further questions. So let's have a look at what people have gone for. So, ooh, that's an interesting split here. So, right, the answer is amitriptyline. So let's look at the incorrect answers. So urinary tract infection. There's nothing to suggest in this history beyond suprapubic pain that this patient has a UTI. They didn't have dysuria, they didn't have hematuria. So, questions in your exams aren't there to trick you. The real world is there to trick you, but in the exams, they shouldn't be that mean. So that's incorrect and was fairly obvious to most of you. Kidney stone in the ureter. So what we have to think of here is if there's a kidney stone in the ureter, which is above the level of the bladder, would passing a catheter through the urethra into the bladder relieve a patient's symptoms if their kidney stone was higher up and causing a blockage? The answer is no, okay? If they had a stone in their urethra and by passing a catheter through, you somehow dislodged it, quite possibly, yes. But they'd be in a lot of pain during that catheterization. And we said here that catheter was passed with ease. Urethral stricture, again, so could be a cause of a post-renal AKI or failure to pass urine. But again, the catheter was passed with ease. And in people with strictures, catheters are incredibly difficult, okay? It's a really difficult bleep to get, usually at the middle of the night where you're asked to come and catheterize a patient because they're in urinary retention. When you try and pass that catheter through, it's just beyond difficult. Bladder cancer, I'm glad to see that no one, or very few went for bladder cancer. This patient developed quite sudden onset retention. Bladder cancer, you'd expect it to occur at a much sort of slower rate, and there's no other features in the history that suggest bladder cancer, which leaves us with amitriptyline. So amitriptyline is a tricyclic antidepressant that's really useful in certain types of pain. And we said that this patient had osteoarthritis, so she was taking it for that reason. And amitriptyline has a side effect, or has anticholinergic side effects. And the way to remember the anticholinergic side effects is to first think about what would happen if you stimulated someone with acetylcholine. okay? And the key features of acetylcholine stimulation are sludge, okay? And a sludge stands for salivation, lacrimation, so tears, urination, diarrhea, gastric upset, and emesis, or vomiting, okay? Salivation, lacrimation, urination, diarrhea, gastric upset, emesis. So when you're asked what are the anticholinergic side effects of a drug, just flip sludge on its head, okay? So it's a dry mouth, dry eyes, urinary retention, constipation, okay? So you just flip sludge and that will give you your anticholinergic effect. So in this case, amitriptyline, one of its features is anticholinergic properties, including a risk of urinary retention. So let's head back to our case. So when we're thinking about the post-renal causes of an AKI, it's usually more helpful to think of it with males than females, only because the males have this extra structure here, the prostate. So, you want to think about every possible cause. And I quite like urology because you can think about the kind of general causes that can affect any part of this urinary tract. So you can get an infection in the kidneys, the ureter, the bladder. You can get kidney stones in the kidneys, the ureters, in the bladder. You can get malignancy and so on. You can get strictures. So if you're ever kind of grilled on a ward round, knowing these general causes and applying them to the anatomy, you'll always be correct. And then you've got some more specific causes that can lead to retention and a post-renal AKI. So things like benign prostatic hyperplasia, or phimosis, where the foreskin has been retracted and is kind of cutting off that you can't retract the foreskin, and so it's preventing kind of urethral opening from allowing urine to leave. They might have a catheter in already that has become blocked with sediment, or it's got a kink in it, and this is really common. So oftentimes, if you're ever bleak to go and see a patient who's got a catheter in that's no longer draining, try and give the catheter a good flush with some irrigation fluid, just to see if you can kind of get the tube patent again. And then you've got to think about the pharmacological causes of post-renal problems. So the anticholinergic effects of drugs such as amitriptyline, and then things that are going to cause constriction of your urethral muscles, so alpha agonists, and also block your dilation, so calcium channel blockers. So these can all lead to retention. So those are the specifics. In terms of investigation, if you recognize that it's a post-renal cause, get urology involved. Again, doing some bloods is important. If you're worried about it being some sort of infection, do your white cell CRPs and blood cultures. If you can get some urine sample, send it off to the lab. And the key one here really is imaging. So if you can get a renal ultrasound that looks at the entire tract, it might reveal stones, or it might reveal some sort of scarring. Bladder scan is really useful. If a patient isn't passing any urine and you do a little sort of ultrasound scan of their bladder and you see that it's massively full, you know that there's some problem between the bladder and the urethral meatus. And if you're worried about stones, the number one sort of diagnosis is a non-contrast CT KUB. So that's one of those classic SBA questions where it's just pattern recognition, CT KUB, non-contrast, looking for stones. And management then, so if they've got a catheter, flush it or replace it, or if they don't have one, try popping one in. Stop their offending medications, so amitriptyline is a classic example because it's anticholinergic. And then treatments, you just treat the specific cause. So they might have a UTI, in which case start empirical antibiotics whilst you're waiting for your urine cultures to come back with their sensitivities. If they've got ureteric stones, you need to follow the specific guidance. I think Azim in the past has done a whole session on ureteric stones, which is well worth finding on YouTube. You know, the management differs depending on what size the stone is. If they've got a malignancy that's causing retention, then you go for surgery and chemotherapy. So you can see here how we've kind of drifted from nephrology into the more surgical specialty of urology, whilst all under this blanket heading of AKI. So, quick recap before we finish up. So, post-renal causes, there's a whole host of them, and it's really important to think of that framework of general causes that you can apply to every step of the renal tract. Distinguishing features of a post-renal cause: it might respond to catheterization. The urea creatinine ratio is pretty useless here. It'll probably be somewhere between 40 to 100. And the key one is to look out for is lower urinary tract symptoms. So they might have dysuria, they might have hematuria, they might have suprapubic pain. Okay, this is not something that we talked about in the pre-renal and renal, because that's not what you'd expect to see. And the management varies depending on cause. So I just wanted to stick this in here as an example of why it's not this easy in reality. So you're in FY1 covering nights on a surgical assessment unit when you are bleeped to see Mr. Jones, a 54-year-old man recovering on the ward 1 day post-op. The nurse tells you that his urine output has been dropping for some hours. You allowed a medical student to change his catheter this morning. You started him on gentamicin and losartan as well. His heart rate is high, his blood pressure is low. So what do people think, just looking at the chat, what do people think could be the cause of this patient's AKI? Okay, so someone's gone for gentamicin, someone's gone for infection from the catheter. Losartan, somebody's mentioned, yeah, so it's an example of an angiotensin receptor blocker. Could be technical issues of catheter insertion, absolutely. So you've hit the main ones, guys, but the key thing to say here is it could be more than one thing. So they're 1 day post-op, okay? Surgery, blood loss, the stress of it all, that could lead to a pre-renal AKI. You could have changed their catheter and in doing so somehow caused a post-renal problem by potentially putting the catheter in wrong or causing some sort of obstruction. The gentamicin could have caused a renal AKI, and the losartan could have caused a pre-renal AKI. So it's not that obvious, but the key thing to remember is be systematic. Recognize that it could be a number of things and address the reversible causes. So begin by saying, well, look, his blood pressure is low. I'll start him with some fluids. If it's pre-renal, it might respond. I should probably also check his catheter, maybe flush it or maybe replace it. Given that, you know, he could, because his urine output's dropping, I should probably do some U's and E's. And if those come back abnormal, then maybe you'd want to stop the losartan and stop the gentamicin. So it's a whole host of things that you could do proactively as an F1 on nights that no one would shout at you for doing, and actually they would probably praise you. So I hope that kind of makes you realize what it's going to look like in reality rather than the simplistic, you know, patients slotting nicely into these different categories. So quickly before we finish, complications of an AKI, what actually leads to death? Well, acidosis is the main complication. So when your kidneys get damaged, they no longer handle acids properly. You can become hyperkalemic, and a response to this is your potassium gets pulled into the cells to try and compensate, and they do that via the proton potassium antiporter. So when your potassium moves into the cells, protons move out, causing acidosis. You get hyperkalemia due to issues with your tubular reabsorption and secretion. So when the tubules are damaged, you get less potassium secretion, so it builds up in your blood. Failure to filter your blood properly can lead to edema. And then these last two here are a little bit less common, but really, really something to be aware of. So if your urea levels rise, you get a rise in blood urea nitrogen, okay, which is otherwise known as uremia. The uremia on its own is an issue, but what the main issue is what it can cause. So uremic encephalopathy, so some sort of functional confusion of the mind, or uremic pericarditis. So essentially inflammation of that pericardial lining around the heart. And so to finish the session, we've got one last question. This is our top decile question. So it operates slightly different to normal, so it'll be a little bit of a competition. So if you head back over to Menti for the last question of the day. So let's wait for a couple more of you to join. And well done, guys, for sticking it out for the hour. I realized that 7 p.m. on a Wednesday is, yeah, we're over the hump now. So you're going to get the question followed by about 30 seconds to answer, all right? And it's fastest on the buzzer. So here we go. Answer fast to get more points. Which of the following complications of AKI is an indication to start dialysis or filtration? So, metabolic acidosis of pH 7.3 or below, refractory hyperkalemia of 5 millimolar per liter or above, history of NSAID overdose, refractory fluid volume overload, or elevated blood urea nitrogen. So, 9 more seconds. Okay. So the correct answer was refractory fluid volume overload. So let's just have a bit of a chat about, why these are kind of right and wrong before we reveal who was the fastest out of these three. So somebody who was very, very clever spotted in the chat early on that the complications of AKI that I showed on the previous slide were all, to an extent, indications for dialysis, but there are specific criteria. And the nicest way to remember this is the vowel mnemonic. Okay, now that is A-E-I-O-U. So starting at A is for acidosis, but it has to be a refractory acidosis. So, it doesn't respond to any treatments of pH 7.15 or below. So they've got to be fairly acidotic to qualify for dialysis if they've got AKI plus metabolic acidosis of 7.15. So that's the A. The E stands for electrolytes, and particularly here it's potassium. So it's if their potassium is 8.5 millimolar or above, and again, it's got to be refractory to that base treatment of, calcium gluconate and insulin glucose. That's E. I stands for intoxication. So there are certain medications that if you've overdosed on and you've got a profound AKI, you might qualify for dialysis. And the intoxication here would be salicylates. Okay, so if you've overdosed on salicylates, like aspirin, then yes, you might qualify for dialysis. So that's the I. O stands for edema or overload. And again, this is refractory fluid volume overload. So if you've tried to give diuretics, which I know we have to be careful with in AKI, but if you've tried to give them and they're still massively edematous in the acute setting, and they have pulmonary edema, etc., then yeah, you might give them they might qualify for dialysis. That was the correct one here. And then finally, an elevated blood urea nitrogen or uremia for 5 days. So the key here is they've got to have a uremic presentation like encephalopathy or pericarditis to qualify for it. So that's the U. So A-E-I-O-U, acidosis, electrolytes, intoxication, edema, and uremic encephalopathy or pericarditis. So let's reveal our winner. Casper, well done. Take a bow, Casper. Very impressive. Unfortunately, there is no prize, but a round of applause from myself. Well done. Good job. So just quickly back to the slides to finish. So this has been a GKT MSA webinar on AKI. There's some references here that you guys can kind of do some additional reading on if you like. And if you enjoyed this session and you enjoy what BiteMedicine has to offer, then please do check us out on Facebook, Instagram. You can drop us an email at admin@bitemedicine.com. If you wanted to ask me some more questions or get in touch with me directly, I'm happy to be added on LinkedIn, Facebook, or email. I'll leave these up on the screen. But yeah, I hope you guys enjoyed. And yeah, we'll see you again soon.